All right, let us dive in. So who is this ancillary person anyway? The ones we're going to cover are on the slide. So if you don't see it there, we're not going to talk about it today. It's coming up on Passover, and so the Jew in me wants to ask the 4 questions. It's a different set of 4 questions than what we do with the Seder. So I think that this is a helpful framework for thinking about any ancillary you're thinking about doing. Actually, almost all Medicare questions in a way. So the first one is, can you do it? And I would note that when you ask us lawyers questions, I'm often guilty of jumping to, will Medicare pay for it, as my main question. And I often think that that's what you're asking me, and that's often the analysis I do. And that's wrong, right? The first question is, can you do it at all? And so that's a licensure question. Is it in someone's scope of practice? In some states, there's a certificate of need or CON question. We'll talk about those. So that's question 1. Then the next question is a geographic one. Where can you do it? Are there limits on where it can happen? And who has to watch over it? Katie is here as my supervision guru because I am not smart enough to handle all this supervision stuff. A lot of this is in state law. Sometimes also, if you just focus on Medicare, you lose sight of there are other payers out there, and they can limit. You may need their approval. I remember working with a surgery center in the Northeast. They opened it up, and that's when they realized all of the payers said you needed prior approval to get payment for them for any new location. And this clinic went, oh crud, we built the surgery center and we can't get reimbursement for any services in there. So you can't ignore the private payer questions. The next question we're going to spend very little time talking about, but it's an important one. It's the Billy Joel song, it was a tell her about it joke. I don't think that one works. But, who do we need to tell about it? And that's mostly a state law question with a couple of exceptions, and a conflict of interest question, which is, do you need to tell patients that you own the thing? Do you need to register with anyone? And then there are a few others, question to ask about. And the biggie, which is what we're going to talk about most of the time, can you bill for it? Which is often a stark question, payer rules, there can be state law on it. Okay, so that's this is the big framework to consider. Things to keep in mind in here. It's super easy for lawyers to say no. I'll have a couple of examples as we get into this. When you're a lawyer and you don't know the answer, you say no because you're afraid that if you say yes, you're going to get in trouble. And so just know that about us lawyers. We try not to do that here, but it happens. Be skeptical of advice on this stuff. If we say something that contradicts what you've heard, push us. We get challenged by this. This stuff is really hard. Don't forget state law. I think of our job as to tell us what you can do. What you should do might be different. We'll come up with ways you might do it. You may not choose. There might be all kinds of times we'll tell you you can and you choose not to. So what are the laws governing ancillaries? And why did I throw an asterisk up there? So I threw an asterisk up there because words matter. And laws is almost too broad. We're not just talking about laws. There are also regulations and there's manual guidance. And so you may have heard about Rachel Brand, who was a DOJ person, or was a DOJ person. She left to go be the general counsel at Walmart right after she wrote this famous memo in January that says the government is not supposed to use guidance as a means to affirm when they seek affirmative enforcement against, I'll put that in other terms. If the government is suing you, it shouldn't be based on guidance. It's got to be based on a statute or regulation. We're going to go broader. We're not just going to talk about statutes and regulations because I think you should know what the guidance is, even though the government shouldn't be using the guidance to stick it to you. So the broad areas we'll be talking about: the Antikickback Statute, Stark, state anti-kickback and Stark laws, fee splitting, as I like to call it, flea spitting, Stark. Stark's on there a couple. Actually, Stark's so important I put it on twice. Supervision, and then also CON. Okay. Katie's going to walk us through the Medicare supervision rules. We're not going to get into Medicaid because Medicaid is state specific, and we've got people on here, I don't know if all 50 states, but most, so it's just not realistic.
Yeah, and there are Medicaid supervision rules that are likely often different than Medicare.
And that's really crazy, but Katie, really different than Medicaid? How can that be?
It's interesting to see what states think is important to be supervised. And
it is so strange that Medicaid is a state program, but it is. All right, so just a little bit of quick lingo on Stark and what Stark and the Antikickback Statute mean. So Stark is a civil law. You can't go to jail for violating Stark, It doesn't care about your intent. If you've got a doctor and they have a financial relationship with an organization, and that organization provides a designated health service, you need to worry about Stark. It's really that simple. And Stark is weird because it applies to referrals only, but a referral is developing a plan of care. So when a doctor says to a patient, you need an MRI, that doctor is deemed to have referred the patient to wherever the patient goes to get the MRI. And that's totally counterintuitive. So people often think, well, I'll just never tell them about our scanner. We'll order the MRI. We won't discuss where to get it. And then I'm cool. And under Stark, you're not cool. That doesn't solve anything. If the patient goes to your scanner, you've referred them there. Okay, so that's really weird, but it's the law. Here's the list of designated health services. We won't read them. You've got it in your handouts. It's long-ish, and it covers most ancillaries. Optical shops aren't on there. Hearing aids aren't on there. And we're not talking about
And there's a list of codes, right?
Yes. Katie makes an excellent point. And where do you find that?
You would find it in the Medicare physician fee schedule.
Okay, Antikickback Statute. It's a felony to break this one. Intent controls. Actually, you're less likely to run into kickback problems with most ancillaries than Stark. There are safe harbors. They're narrow. You do not need to fit within one, all right? I will just note, also, the Antikickback Statute, people go a little crazy on this. I had a big law firm recently, right? This doesn't fit within a safe harbor, suggesting it's illegal. And that's just factually incorrect. Most deals don't fit within a safe harbor. It isn't important to fit within a safe harbor. So we won't talk a lot about anti-kickback because it is less of a problem. For this reason, in part, if you're talking about payments within an entity, the anti-kickback statute doesn't apply for the language that's in purple here. I'm not going to read it. It's in the slides. Basically, if you're within a corporation, payments aren't kickback problems. Tax-exempt stuff only comes up when you're dealing with a nonprofit. So if your clinic is a nonprofit or there's a joint venture between a nonprofit hospital and a for-profit clinic, you need to know about the tax-exempt laws, which basically prohibit private inurement, which in plain English is someone getting more money than they should in a relationship with a tax-exempt organization. And the government can apply intermediate sanctions to come claw that money back. Certificate of need. I don't know the exact number of states, it's in the 30s, that still have a CON. It is crazy to me that CON exists. It is an artifact of cost-based reimbursement when the government was saying if you built it, you got paid to do it, so we're going to prevent you from building things. It kind of encourages monopolies, right? Conceptually, it's very un-American. It's this idea that to build something, you need a government blessing. Very Soviet, frankly. But in an era of cost-based reimbursement, it would make sense. I think insurance companies might like them because they prevent you from, it lets them ration care without them saying no to a service. It prevents there being too many of them around. It also, though, prevents competition on price. I think that these laws should be gone. I relish the day of getting to challenge one on a policy basis, although often it will not be a judicial challenge, it'll be a legislative challenge. Many states have exceptions for things, like maybe if you're doing it in a physician office, it's okay. Maybe if you're doing it with a hospital, it's okay. Sometimes if it's under $1 threshold, it's okay. You just have to know your state law. I will say this, if you are looking at CON stuff, if you need to go to a hearing, use local counsel for us. I mean, we work with people all over the country. I would not tell you to use us if you've got a CON issue that you're dealing with in a remote state. You want to have someone who's done it before and who knows the ins and outs and knows the players. This is a political process, so use someone local. Okay, I think that that's enough on CON. So state laws almost, well, and the same thing. In the 30s of states have state anti-kickback statutes. Some are broader than the federal law. Almost by definition, it's broader than the federal law because it will apply to people that are not Medicare and Medicaid. And fee-splitting statutes, which may prohibit you from sharing revenue with non-physicians and the like. And I would say most states say that when a doctor has a financial interest in an organization, the physician needs to disclose it to his or her patients. That might appear in a specific statute. It often appears in like the state medical board ethical principles, so you can get there that way. And some of those things will tell you, now, one thing to keep in mind, telling the patient might have a specific thing. Maybe you have to post it in 20-point font on the wall, right? There's often a possibility there.
Yeah, that's a perfect exact example. Certain font size and bolded in some cases.
Which, yes, I was going to make some font joke, but we're a font of info. Okay, moving right along. The Medicare framework. So this is kind of weird, but Medicare tends to think of things as either diagnostic or therapeutic. And that difference can impact the entire regulatory analysis therefrom. Under Medicare, often a therapeutic service has to be incident to a physician. And Katie's going to talk a little bit about that. It's different in a hospital. Now, diagnostic tests, I would have told you until, I want to say it was 2001, I would have said diagnostic tests are incident to. And then in 2001, CMS came out and said, oh, you idiots, it's not, because they're under a different provision of the Social Security Act. Incident to is 1861 S2 of the law, and diagnostic tests are 1861 S3 of the law. And they say different statutory provision, different supervision framework, and the like. And that's going to matter in some weird ways, as we'll talk about. But like one of the biggies is that the supervision requirements for diagnostic tests are different than the supervision requirements of therapeutic services, okay? So ask yourself, are we talking about a therapy or a diagnostic test? That also has implications for whether you can credit people in the comp formula. And we'll talk a little bit about that.
And I would say if there's a question, get code specific, because you can figure out whether something's considered diagnostic by going directly to the fee schedule and looking up to make sure that you're on the same page as Medicare.
And that also will tell you the level of supervision that's necessary. And so Katie's point is a great one. So where can you do this? Well, supervision becomes an important question. We'll be talking at length about where stuff is. You have to make sure that wherever you plunk it, you've got sufficient supervision. If it's hospital-based, you're either going to have to do it on campus, which means within 250 yards of the main hospital building. So go to the outer wall of the main hospital building, use one of those little roller things, and it's 250 yards in a circle. That's where you go.
And also, if you are hung up on whether there can be more than one main hospital building, there's definitely some wiggle room there. So if you're hung up on that problem, call us, because we've been there.
And what we mean by that is call Katie, because she's been there. Katie and Breyer are the people who have wrestled with this a lot. Okay, and then, so Stark sets limits on this, and I think we'll talk about this when we come to therapy. People get this wrong all the time. I just got a new client who had been told by their lawyer for years and years and years they couldn't do off-site physical therapy under Stark, and that advice is just plain old wrong, because Stark lets you do their designated health services in a centralized location, which in plain English, if it's yours, 24 hours a day, 7 days a week. In other words, you're not sharing that, and it doesn't have to be the whole building, but the space in which we're talking about, the leased or owned space, is yours 24/7. You can use that fine as long as you can meet the supervision requirements there. So they got bad advice from someone, and they, for years, thought that they couldn't do off-site PT. Now, it's different in the hospital, and this is super duper complicated. But basically, if you're talking about an outpatient therapeutic service, you have to do it either inside the hospital or in a department of the hospital. So operationally,
chemo.
So chemo. So let me I'm going to think maybe if it's chemo, because chemo is a therapeutic service, I want to go with hyperbaric.
Okay.
Because it's therapeutic, and chemo you probably don't do in a truck outside.
Sure.
I suppose you might. But mobile hyperbaric. So how would this matter for mobile hyperbaric?
Well, if you have mobile hyperbaric, you're not necessarily in the four walls of the hospital, although you would make the argument that if you are joined up to the hospital, then you've created part of the hospital and you are therefore within it, if you're not able to meet the other test.
So if you're parked right alongside the hospital and you walk in, you're probably good. If you're parked a mile away, a lot hairier situation. And so weird thing, if you've got a therapeutic service off-site, it's more complicated.
You want to incorporate it into the four walls as much as possible.
Or make sure you meet the provider-based rules.
Right.
That's really the ultimate thing there. All right, so if it's therapeutic under Part B, under outpatient stuff, it's got to, you have to do it yourself or under arrangements. And under arrangements basically means it's a contractor. But if it's therapeutic, we still have this problem of we want to be in a department of the hospital or in the hospital itself.
So under arrangements isn't as helpful as it is in a diagnostic setting where you don't have to be in the hospital, but I'm jumping ahead of us.
Well, not really. Let's go. So let's jump to that because So I think that's a good point, Katie. So let's finish that thought.
So, the diagnostic tests can be furnished under arrangements, as can therapeutic, but oddly, and for no obvious reason, the regulation governing hospital outpatient diagnostic tests does not also have the requirement that the test be furnished either in the four walls of the hospital or in a provider-based department. So in other words, a hospital can provide diagnostic tests under the outpatient PPS done under arrangements, but the space in which the tests are done doesn't need to be meeting a provider-based department. All right, so the topic of Medicare supervision has a long and tortured history, and there are a lot of different components. So we're going to talk about sort of broadly how to analyze them and some high points of each. But just be aware that when you are asking the question of how something has to be supervised, there are some sort of threshold questions that are going to get you to the right place, or if you answer them wrong, to the very wrong place. So for Medicare purposes, the supervision is also dictated by whether something is diagnostic or therapeutic. There's a lot of overlap between the standards, but you have to first know diagnostic or therapeutic. Diagnostic tests are going to be assigned very formulaically in the Medicare physician fee schedule, a level of supervision. That's either going to be general, direct, or personal. And the fee schedule has codes for saying what a diagnostic test has to be supervised as. Number 1 is general, number 2 is direct, and number 3 means personal.
And 9 means it doesn't apply.
And 9 means it doesn't apply, so you're probably in a therapeutic service. So that's the way to sort of tell if you're in diagnostic test land. If you don't have a 1, 2, or a 3, then you might not be diagnostic test land. On the therapeutic side of things, it's a little tricky because you have therapeutic that's hospital outpatient therapeutic services, and those have defined supervision levels that we'll talk about, but not in the same coded way that the diagnostic tests do. And then therapeutic services like chemo would be an example if done in the clinic. Those services have to be, if they're therapeutic, they have to be done incident to a physician or other professional service. And those have specific requirements for billing. And then not all, however, things that you would think of as therapeutic are going to be governed by either the incident to rules or the hospital therapeutic rules. So there's the group of special therapy, I like to call it, which is PT, physical therapy, occupational therapy, and speech language therapy. And those have their own separate benefit categories and separate levels of supervision.
And I can't think of many others, but there might, if it's got a separate benefit,
yeah,
that's kind of where you go outside of incident to. So this is confusing to us. So if it's confusing to you, we get why, but that's kind of how you go.
All right. So quick note before we get to supervising. We're talking about supervising Medicare diagnostic tests. There are also some rules about who can order diagnostic tests. Remember that only the professional who's treating the patient can order. And in the circumstance of who can order a diagnostic test, that can include the treating physician or a treating non-physician practitioner that we've listed here.
And only the ones listed here.
And only the ones listed here. So many types of professionals that are listed here can order the diagnostic test. However, when it comes to supervising a diagnostic test, whether you're in the hospital or in the clinic, you have to have the supervision done by a physician. This is where people get tripped up a lot because they think, oh, a nurse practitioner can order because they're treating, and then that person can just be the one supervising. Not true. For diagnostic tests, you have to have physician supervision.
Which is crazy. And so like a nurse practitioner can supervise chemo because it's therapeutic. They can't supervise a plain film x-ray.
Even if they could do actually perform the X-ray under the state
So
scope
this
of practice.
is crazy, but it's the way it is.
Right. So these levels for diagnostic tests, what do they mean? Now, general supervision is the lowest level of oversight. And general supervision is defined as the procedure being furnished under the physician, again, remember it has to be a physician for diagnostic tests, under the physician's overall direction and control, but the physician is not required presence is not required during the performance of the procedure. Now that begs the question, can this be the physician on the golf course scenario, the classic scenario? And our answer would be yes, the physician cannot be present. They can be out on the golf course or probably actually doing something more productive than being on the golf course. But remember that under general supervision, whoever is performing the test, they're performing the test, and the maintenance of the equipment and supplies are the continuing responsibility of the supervising physician. So what does that mean in practicality? Well, if you have a scanner and a bunch of tests are general supervision tests, which is very common, so you don't have to have a physician there, but the techs and the techs are asked about a particular scan, does the tech know who to call? The tech should probably know who to call, because under Medicare, at least, Medicare expects the physician to be responsible for the oversight of that test.
So I'm going to back up and interrupt for a second to go back to the craziness of like the nurse practitioner not being able to supervise a plane. So I'm going to say, I would, for giving advice, don't have your NP supervise. If you ever had an overpayment situation because of that, I'd totally challenge that on this is so crazy, it's like maybe even arguably unconstitutional or something. It's crazy. So just as an aside, that's sort of the difference between how you analyze things prospectively and retrospectively. So what's direct supervision mean? People just stumps all the time.
So direct supervision for the diagnostic test in the clinic means that the supervising physician, again, it has to just be a physician, must be present in the office suite and immediately available to furnish assistance and direction throughout the performance of the procedure. Okay, well, a couple things here. There's a geographic boundary. What does it mean to be in the office suite? Well, the office suite isn't defined in the regulations, so that's important point number one. We know that it's not necessarily the same room. Suite obviously implies that. The Federal Register commentary has suggested that a suite could include rooms on different floors, and here's the language that you should pull if you're either arguing about it or trying to find more insight. So a group of contiguous rooms could be considered a suite, but in the end, it's going to be up to the local contractor to exercise its discretion. What I think is funny here is that at the end of this quote, it talks about physicians practicing in a townhome, which never ceases to sort of make me chuckle. But you can have two levels.
This is a proposed rule.
Oh, right,
wait, hold on. Actually, it isn't a proposed rule. This is preamble to a proposed rule that was never adopted.
Right.
And it also ultimately gets to, it's up to the contractor. And there's a giant part of me that says if the contractor has discretion on this, it's not a rule. So I think this is another one where you have to decide what risk you want to take.
Yeah, and I think you have to be able to say that if you're going to be immediately available, you have to be able to get to the patient within a relatively quick amount of time. Personal supervision is the most onerous in terms of requirement, but it's super easy. The physician must be in attendance in the room during the whole performance of the procedure, not just part of it.
That's an easy one.
All right, we're going to kind of quickly go through IDTF. Know that if you are running an IDTF, there are still supervision requirements for diagnostic tests, but they are heightened. There are limitations on the number of sites the physician can generally supervise. The supervising physician has to have certain credentials and qualifications. You have to report the supervising physicians to Medicare. And there are several enhanced supervision requirements, so make sure you pay attention to those. If you're
try not to be an IDTF.
Yeah, right. Maybe just try not to be an IDTF. It's hard to share space there too. So then we're still talking about diagnostic tests, but moving to the outpatient department.
And hang on, I'm just going to say, because outpatient, this is another lingo.
Right.
This outpatient doesn't mean clinic. When we say outpatient, we mean outpatient hospital.
Hospital department, provider-based department. So in the outpatient department or in the outpatient hospital, you still need physician supervision. The Medicare physician fee schedule is still going to be the one that assigns the level of supervision. But note that there's not this office suite requirement because it contemplates that you could be somewhere in the hospital. Though if you are doing diagnostic tests under arrangements by the hospital, but not in a hospital space, you would need to be in that space. So that's just a little quirk there. But direct supervision in the hospital is not going to be geographic limiting. It's only going to say that you need to be immediately available to furnish assistance and direction throughout the performance of the procedure. To me, that means you have to be both interruptible, what you're doing has to be interruptible, and you have to be able to get to the patient relatively quickly in order to do the next step. So let's switch gears now to outpatient therapeutic services. So the sort of classic therapeutic service, one is chemotherapy infusion, hospital observation. This is a different framework for assigning levels of supervision. You don't have the codes under the fee schedule. What you have is basically a general rule that outpatient therapeutic services, and remember not PT, speech language, or occupational therapy, anything that's not diagnostic or those three things in the hospital, that's how I like to think of it, have to be under the direct supervision of a physician or a non-physician practitioner, certain of those, which we've listed here. So now we're getting a little easier in the outpatient setting for therapeutic services. It doesn't have to be supervised just by a physician. It can be other folks too. Except cardiac and pulmonary rehab programs. Those have to have physician supervision. So it's thorny, but
really thorny?
Very important to sort out. The exception to that direct supervision rule is that non-extended duration therapeutic services, so like really long infusion procedures or things like hospital observation, which could stretch for several hours, those, if they are listed in a special list by CMS, can begin with direct supervision when the procedure is started, and then once the initiation of the procedure is over, then they can be supervised generally. So note that this more onerous direct supervision requirement may not apply to those services that you think of as stretching on and on for many hours but not requiring a lot of work.
Okay, so now we're going to move on, and I'm so glad Katie did, because I can't handle this. So, all right, this is a bit of a segue, right? So you need a written order to do diagnostic tests, right? And so crud, we don't have one, are we toast? And so this is one where we're going to look at this manual language. And the manual language says, if the signature is missing from an order, disregard the order during a review. So a couple things to note. First, remember that little asterisk about the brand memo? This is guidance, right? So if it's in the guidance, we would not say that Medicare can enforce this off the top of immediately. But this is where this is one of those arguments, every now and then you feel kind of proud as a lawyer. This is one of those proud moments. Because you can say, not so fast. So in Halloween 1997, October 31st, the physician fee schedule came out. And Katie's talked about the physician fee schedule. It's important to note, usually in November, this time it was October, sometimes December, the fee schedule comes out. It often has new rules, and then it always has the list of diagnostic tests and what's considered a Stark service and the like. Well, in the preamble in 1997, it said that they were imposing a higher level of scrutiny on IDTFs. They have to have written orders for diagnostic tests, whereas other people don't. That's completely inconsistent with what is in the manuals. I am sure that whoever wrote the manuals forgot that this is out there. And what it highlights, Katie and I we say this a lot. If you're going to refund money, if it's more than a few $1,000 bucks, please call one of us and just talk for 10 minutes, because we can often get you out of, we've had a bunch of times, oh, we don't have written orders for the diagnostic tests we're refunding. Oh, no, you don't need to, and here's why you don't. So that's just a bit of a plea, because we hate hearing that you've refunded. I've had a client, yeah, it was $1 million. They refunded $1 million they didn't need to refund. So it makes me feel bad. All right, we've kind of covered the who must we tell, but there's a little bit more in there. So it's mostly a state law thing, and remember, they may tell you how to do it. There are quirky things. Some states, Minnesota, has a capital expenditure report that is so easy to forget about. If you're spending, God, it's so easy to forget. I don't remember the amount of money anymore. I want to say it used to be $500,000. I'm embarrassed. I do not remember this, but there's an amount that if you spend in Minnesota or in a bunch of other states, you've got to report it. 855 forms. What do you have to put on your 855 form? It's like
you have to put on, well, a lot of things that aren't necessarily related to ancillaries, but the one that I think of is practice locations. If you're adding a new practice location under a current enrollment, then you need to report that.
So if you start providing PT off-site, you need to put that on your 855
and
form.
Within 30 days.
So, and then there's this, the advanced imaging notice. So if you want to be a group practice under Stark, and hospitals may wish to consider this because it gets you more flexibility and compensation, whenever you do what Stark considers advanced imaging, which is MRI, CT, and PET scans, you've got to give every patient at the time that you tell them to get the scan, either hand to them or email to them, a notice that says, here are at least 5 suppliers, i.e. people who provide this Part B. You don't have to list hospitals, just IDTFs and physician practices that are within 25 miles. You can say whatever the heck else you want to say, but you got to say that. And if you're a physician clinic and you're doing MR, CT, and PET, if you're in an urban area, you need to do this. If you're in a rural area, you don't necessarily need to, but I think you want to. All right, so if you're in even hospitals care a little. How can you divide the money, all right? Often doctors want credit for the work they do. Well, doctors under Stark can't get credit for their referrals, all right? At least not typically. And so you have sort of Stark issues, you might have state law. You also have to think about, there are non-legal issues about collegiality you have to think about, and tax exemption type stuff. So under Stark's group practice exception, you can't give doctors payments that vary based on the volume or value of their designated health services referrals. So if it's a DHS, you can't pay the doctor for their Medicare and possibly Medicaid stuff. So you could, for private pay, don't like that idea because you screw it up too easily. Things the doctor does him or herself, those aren't referrals. But a doctor can't get a credit in their comp formula for every scan, every lab, every PT that they order. What about if they supervise them? Now, if they supervise them, if you're a group practice, and if the thing is incident 2, then you can get credit. But here's what's weird. So if it's a diagnostic test, remember those can't be incident 2. So you can never get credit for the diagnostic tests. So no lab and no PT that way. But if it's physical therapy, technically, if you supervise physical therapy incident 2, you can get credit. If you chemo incident 2, you can get credit. Those are the list of designated health services. An often overlooked thing in Stark, but it applies way more than you might think. If you get less than 5% of all of your revenue from Medicare and Medicaid for designated health services, and no individual doctor gets more than 5% of his or her comp from DHS, you can blow this off. It's basically, they just ignore it. So you have to run the numbers, and it depends kind of on A, how many ancillaries you got, and B, how big your Medicare population is. Now, Stark does not require you to divide money evenly. People often think it does. It doesn't. You can do it however you want. You can pay on RVUs, as long as you don't give people RVU credit for their designated health service. You can pay on RVUs and services that would be designated health services but are for private pay. As I said, I get nervous about that because I'm worried about screwing it up. You can choose some method for allocating things that's fixed and do it. So you might say, our spine surgeon is going to get a higher share of PT but less of imaging. And you just fix it, and it's established, and it goes in perpetuity. That's okay. Anything, you can do equally, seniority, predetermined. You can have subgroups of 5 or more doctors. You can do any combination of these things. It just can't be linked to who ordered the service. Within the hospital, there's an extra layer under Stark, which is you can't pay more than fair market value for the work that's done. You can credit the physician for non-designated health services that are incident to their work. So if they're working with a PA or an NP, they can get credit for that. And I'm in a case right now where the government is like, no, you can't. Yes, you can. It's really clear from preamble language and statutorily that they can. So they can also get credit for designated health services that are incident to if they're a group practice and the thing can be incident to. But now, remember, to be a group practice, There are certain hoops you got to jump through. We're not going to get through all of those today because I have too many stupid slides. If the doctor does the thing him or herself, they can get credit for it. This handy-dandy chart out of the Federal Register helps differentiate what you can get credit for in the various exceptions. And so you'll note that in the group practice situation, there you can get credit for stuff that you personally perform and designated health services that are incident to, whereas for the other exceptions, it's only those you do yourself. And you can see where written agreements are required and the like. We love this chart. So the in-office ancillary exception is narrow. So it's designed to cover things you do in your clinic if it's done by the doctor or under that doctor's supervision, but it carves out DME. And this is another lingo thing. People often, when they say DME, they're thinking of braces. They're thinking of prosthetics and orthotics. So there's DMEPOS, durable medical equipment, prosthetics, orthotics suppliers. The POS part of that is different than the DME part of it. So I try to avoid using the term DME when I'm talking about braces or prosthetics or orthotics. Because true DME, doctors can't own in an urban area with the exception of crutches, walkers, and manual wheelchairs. It's carved out of Stark and treated differently. So CPAPs is that first continuous passive motion machines. Those are kind of the two I think we get the most questions about. Doctors in an urban area can't own those under Stark. It's not only that they can't get credit for them, they can't do it for Medicare and Medicaid.
Yeah, the sleep lab is probably the quintessential law school exam for all of these questions.
And it's funny because we're kind of putting you to sleep with this right now, right? And then Katie brings up the sleep lab, it's apropos. Okay, I got a lot of slides to cover, so I'm going to be going quickly here. Can you share ancillaries? Often, yes. This is the twilight zone, right? Like, you can have an ASC, but the space has to be used exclusively by the ASC during its hours of operation. So you couldn't have like a scanner in there that you're sharing with someone else. A clinic can't share space with an independent diagnostic testing facility. There are all of these strange rules. So yes, you can share them. You have to pay attention to this stuff. An advantage of sharing them is, frankly, everyone makes more money, and it lowers healthcare costs, actually, because you avoid redundancies. But generally, if you do it alone, it's less risky than doing it with someone else. The more people in your joint venture, the higher the risk. There's a fundamental urban-rural distinction. If you're rural, which means you're not in a metropolitan statistical area, and 75% of your patients live outside of a metropolitan statistical area, a lot more is possible. If you're wondering if you're in an MSA, that's a census thing. You can send me an email. I'll send you, it's a little hard to find, but if you Google metropolitan statistical areas census, you can kind of find out what they are. But it's in the Census Bureau. So in an urban area, generally speaking, if you want to include Medicare and Medicaid, you're going to have to be in the same building to make things work. Joint venture is a confusing term. We're not talking about marijuana here. If we were, we would get Kevin Rich, our expert on the legal distribution of marijuana, not because he smokes it, but because he knows the legal elements of this. Joint venture in this case is sharing stuff with other people. There are a whole bunch of ways to do it. Now, there are a variety of myths out there. One is a bulletin that the OIG put out in April of 2003. And it criticizes turnkey arrangements. The government doesn't like the idea of a clinic, or I suppose even arguably a hospital, but certainly a clinic, saying to someone, you operate this ancillary for us, we will bill for it, we'll pay you, we'll make a profit. And they would say that if that's the description of what you're doing, it's illegal. That's too simplistic. We don't buy it, but you need to know that that's out there. I think the way to think of it is if you're making too much money, then you should be a little nervous about this. If you're outsourcing something, would someone do this if there wasn't a referral relationship, and is your return B commensurate with your risk? Those are kind of the macro questions to ask. If you're talking about a therapeutic service, therapy, you're in a rural area, a great idea there, you can create an entity to provide that therapy. And you can have multiple clinics, multiple hospitals, clinics and hospitals, own the entity, divide the money based on ownership. This is usually going to work. It'll work under Stark. It'll just generally work. Now, if you're not in a rural area, if you're urban, it's a lot more complicated. And a few things to keep in mind. If you're in an urban area and you're creating an entity to do this, that entity under Stark probably can't be the thing that provides the service. It can do some portion of the service, but if you put in the imaging context, if it's both the equipment and the techs, so the whole service, that's probably not going to work. You might be able to allocate costs amongst a participant, but probably not per click, at least if we're talking about equipment and space. You might be able to do per click. You can do per click for staff, but not equipment and space. So it's an option, but it's just more complicated. Now, I've got a bunch of slides that I'm going to do really quickly because they're designed to be read on their own. So if you have two clinics, can they share things? Well, if it's not a designated health service, then it's primarily a state law issue. If it is a designated health service, you almost certainly need to be in the same building if you want to do Medicare and Medicaid. If you're going to carve Medicare and Medicaid out, then you just have a state law question.
Well, it's interesting. Let's say if you have a DMEPOS supplier, you can't be co-located with one of the clinics.
Oh, that's an excellent point.
There's still just another layer of question.
Yeah. Now, Stark says that when you share space and equipment, you have to have exclusive use. And this is another area where there's a bunch of bad information out there. A lot of people will say that that means you need a block lease. It's got to be for 3 hours. That is not what the government says. What the government says is that, in effect, this for established blocks, because the use has to be exclusive. Well, when you call us and we talk to you for 6 minutes, a point one, you've got our exclusive use. You do not need, I mean, I'd love to say every time you call me, I'm billing you for 3 hours because I have to be in my exclusive use, and I'm sorry, I can only do it in 3-hour chunks. Actually, I wouldn't love that because it would feel really crappy. But in any event, it's not true, right? And it's not true for MRIs. You don't have to do it in 3-hour blocks. I'm sorry, that's just a lie. So here's what CMS says. What we'd tell you is it has to be exclusive and there's not a temporal limit on that, all right? So what is supervision? And Katie talked about this, right? She used the tech has to know who to talk to principle. When you've got a diagnostic imaging joint venture, the tech has to know who their boss is. And so if you've got 6 people supervising, that makes things confusing, and you got to make sure your tech could answer the question, who's supervising? Now, if you're rural, you've got the option of creating an independent diagnostic testing facility. We hate independent diagnostic. I mean, that's a little too harsh, but they're complicated. They have all kinds of crazy rules. They can't do direct marketing. I mean, it's just, there are many layers of rules. So you just need to know, and you probably have to get your own provider contracts, and it's hard. And then there's this weird thing. An IETF can't share space and equipment with anything except a hospital. Yuck. I've alluded to this, but this is just a thing to put in the back of your mind when you're dealing with Stark. Stark cares about who bills for a service and who's providing it. And so if you've got a turnkey service being provided, you may have to do a Stark analysis of both the person that bills and whoever your turnkey supplier is. Can you do a per-click lease? The short answer people often give is no. That's too simplistic. The true answer is it depends, and here's what it depends on. If the doctor is the person who's getting the clicks, they own the thing and they're getting paid per use, and the doctor orders, it's a problem. If that's not the case, it's okay. So if you've got a mobile imaging company that's not physician-owned, or it's physician-owned, but the doctors aren't people who order scans because they're not based in your area, per click is totally fine. It's only a problem if it's per click and the person getting those clicks is also ordering. So here's the part where I'm going to go really fast because this is designed for you to be able to read on your own. Can 2 clinics in a building share a scanner if you don't do Medicare and Medicaid? Yes. Otherwise, if they're both in the building 35 hours a week and the techs are supervised, then probably yes. If you're not operating 35 hours a week, it's way more complicated, and we've got slides at the end that we will give you a guarantee will make your hair hurt and make you hate us. They appear after the questions as to kind of, it's the same building test. Good luck. I understand it now. I believe it took me 10 years. I can't articulate it in a way that will be fun, so we'll just blow through that.
And that's a Stark thing, right?
It's a Stark thing. Thank you. That's, yes, excellent point. Can two clinics across the street share a scanner? Not if they want to bill Medicare. Can you lease time on another group's scanner? Yes, but if you want to bill Medicare, we're back to kind of that same building test. This is a personal favorite. Can you accept outside referrals? Katie, I think that this is the first time you and I ever worked together on a question, I believe, was this question.
That's right.
It was for a client of ours in Alabama. I remember it well, because you were able to explain to them how the information they were getting was totally wrong. They were told, I believe, that they couldn't accept outside referrals, and because
for scans, right?
For scans, they had to be an IDTF, right? They were going to have to be an IDTF.
Right, and they were being told that because there was this manual language that said if there's a substantial portion of the entity's revenue from outside referrals, then you have to be an IDTF. So someone wasn't reading that very carefully, because if you think about accepting outside referrals of scans in a physician clinic, you're not going to have a substantial portion of the entity clinic's revenue being from those outside occasional scans. Moreover, this language is now gone.
And I think it was even gone
at the time.
Yeah.
Yeah. So
now,
don't worry about that language now.
So it was interesting, because this is how I first worked with Katie and got to know her. It was a client in Alabama, and I'm going to mention that for two reasons, totally selfish. Selfish reason number one, I've been to 49 states. I haven't been to Alabama. If you're listening to this in Alabama and you need a speaker in Alabama, please call me, because I need to get to Alabama before I turn 51, because my goal is 50 by 50. And I am 50.
4 months away.
Yeah, at the time of the ticking, man. And second reason, and this is selfish, I guess, also, but sometimes clients will, or sometimes people who listen to this say, boy, we wish we could use you as lawyers. And you can't. You do not need to be a client to listen to these. Heck, we've got other law firms that listen to these. But we would love to have you as a client, and we help people who've got clients in a whole bunch of states, so don't be afraid to ask. We would love to help you. I stuck this in mostly because I realized I had no cartoons, I had no pictures, and I liked that picture. And also because sometimes things jump out and surprise you. And a whole bunch does here. So also, the whale is the opposite. When I type anti-markup into spell check, I always get ant markup. And I don't know what that means, but whale seems like the opposite of ant. So the anti-markup rule for diagnostic tests. Medicare says that if you can't mark up a diagnostic test bought from someone else. And so it applies unless you share a practice with whoever is ordering the thing. And so if you're getting imaging from someone that's not you, if you're not supervising the test, you can't bill Medicare more than you pay the person who's providing you that diagnostic test. This is only diagnostic, not therapeutic. It's only Medicare, although Medicaid in a bunch of states has a variant of this rule in some shape, way, or form. Now, I think Medicare has overstepped its authority because it also applies this, for what it's worth, to the professional component. And it's ironic because this gets to when we were talking about why diagnostic tests can't be incident to. It's a different part of the statute. The same thing is true here. And this is what CMS said. Although Congress didn't establish an anti-markup provision for the professional component, the omission may have been inadvertent. And so I think what they're saying there is, yes, Congress didn't do it, but we're doing it anyway. They don't get to do that. The backup is in here for that's purely for lawyers, right? I'm not going to go through these slides because we don't have time. If you're a lawyer and you want to understand the reasoning, you can see it there. CMS has overstepped its authority. All right, DME. And just another reminder, when we say DME here, we really mean durable medical equipment. Physicians can't own DME in an urban area. If it's prosthetics and orthotics, that's a different critter. Beware of supply closet joint ventures. If someone's giving you the DME and they're putting it in your closet, especially, oh my God, if they're leasing a closet from you, if the lease isn't for something that is available on the open market, that's no good. So if you can't lease, I believe even if you go on Craigslist, I'm going to say you can't lease a shelf. I'm going to say with some confidence.
At least the rent's going to be very low.
That is true. You can probably get all kinds of other stuff. All right. I was thinking I had a variety of completely inappropriate things. We're skipping all those. So what's the issue with these revalidation surveys? What can go wrong with DME and revalidation surveys? Well, the biggie is if someone shows up at your door and comes to take a picture and the hours on your door are wrong, let's say you're under construction and so you're closing early, they'll take away your number.
For more than for
2 years,
years,
right?
2
Yeah.
years.
If they come in and say, we want to take a picture of your shelf, right? And your person behind the desk thinks wisely, why would we let you take a picture of our stuff? Get the heck out of here. Well, bingo, you now lose your number for 2 years. And we've had that happen with clients. It really is crummy. All right, ASCs. I have a bunch of slides on ASCs. The good news is we can do it really quick. ASCs are a piece of cake. There's one question I cannot answer for you, which is reimbursement better as a hospital-based department or as an ASC? I still have not figured this one out. I do not know.
Well, now it's different because fewer hospital-based departments are getting the provider-based rate.
That's also true. And if you are getting it, I don't know the economic impact here, and I've struggled to get other people to tell me. But to get the hospital reimbursement, as Katie pointed out, you got to be on campus. An ASC can be anywhere. Now, there is a safe harbor for ASCs. It is crazy narrow. You will not fit within it. It doesn't matter. And this is another place I see lawyers say all the time, you have to be within the safe harbor. I'm doing a deal right now, and they're like, well, we won't do this. We won't let your clinic in, David, because the clinic has non-surgeons in it, and therefore we won't meet the safe harbor. So here's the main point I want to make. So we can just skip through some of these slides. The real question is anyone paying for referrals? You don't want to let primary care physicians invest as individuals. If the whole group is in, that does not give me anxiety, all right? Here's the ASC safe harbor language, and we're going to skip to this last one that is in color. If you do a joint venture between a clinic and a hospital, in order to fit within the safe harbor, the hospital can't be in a position to make or influence referrals directly to any investor. CMS has said that the way they interpret that is that if the hospital has primary care docs and it's in the hospital service area, you don't meet the safe harbor. Well, guess what? No hospital in the history of the world has put up an ASC outside of its service area. So no ASC physician joint venture in the country meets the safe harbor. I will say that unless the hospital doesn't employ a single physician, then maybe. But I don't think that's very many hospitals anymore. So you don't need to meet the safe harbor. Don't get stuck on that. There's collateral on that, right? There's the 1/3, 1/3 test. And people say you got to meet the 1/3, 1/3 test. Well, that's in the safe harbor. You may choose to meet it, but you don't got to meet it. So you can do it. You're not going to be in a safe harbor. The key points, all right? If there's if there's a venture between a hospital and a clinic, sometimes there are people who think, oh, it has to be 51% control in the hospital. That is not true. They often will talk about the Redlands case. That's a case where an entire hospital was put into a joint venture, and the IRS said, if you can't put the whole hospital into a venture and cede control to a for-profit company. That's not what's happening in a service line joint venture. We hear this less than we used to. That's kind of old, but it's out there. All right, and good anti-kickback analysis is a phone call. It's usually a 20-minute phone call, so don't worry about spending a boatload of money on it. All right. Can you have multiple ASCs? Yes. It creates havoc with the 1/3 ownership test. You don't need to. I had a quirky question from an organization that had 2 ASCs that they were in joint ventures with 2 hospitals in town. You got to think a little bit about antitrust there. If you've got, those ASCs are technically competitors, and so it's just something to keep in mind. Be aware of potential price fixing issues. All right, we're coming up on the top of the hour. We will crank through the rest of this stuff in pretty fast here and still have time for a few questions. If you're a physician group listening to this and you want to have more throughput in your ancillaries, divisional mergers allow an interesting option for you. So that's a way of doing this. You become one corporation, and it solves a lot of Stark problems. It also solves a lot of antitrust problems. And people worry about becoming one group because they think they'll have the whole market. That is not a big worry because the barriers to entry in the physician marketplace are so small. If you've thought about doing some sort of merger and you've said, I'm not going to do that because we'll have too much of the market, give us a call because I think we can help address that concern. Lab. So I had a client that got a call from the government Well, you've got this doctor who's got millions of dollars of claims going out under his name. What's the deal? Well, he was supervising the lab. So the lab services have to be billed under the doctor who supervises them. So that might mean you show up on the list of doctors who bill the most. Lab drives me crazy. It's so hard. But there is a big restriction on lab. Only the lab that performs a service can bill, unless either the lab is in or part of a rural hospital, the referring lab is wholly owned by, or wholly owns, or has parallel ownership with whoever performed it, or no more than 30% of the lab tests are sent out. So those are three, they're pretty big exceptions, but know the general principle is that he who does lab must bill the lab, or to be gender neutral, they who do the lab must bill the lab. Can you have different lab fee schedules? Like, can you, if you're billing some people, can you bill them one amount? This comes up a lot in DermPath. We're going to bill, we will have a DermPath lab, we'll sell it to clinics at X, we will bill Medicare to X. Well, it's the ratio that matters. A small discount is almost clearly okay. There are advisory opinions that say if you're doing bulk billing, we recognize that makes things cheaper, and so we'll let you bill a lower amount then. But I think that we're talking about a 5 or 10% discount. I see situations sometimes that are a 50% discount. This is an area where I am more cautious. I've seen colleagues that will bless that double markup. I'm nervous about it. So for what it's worth. Therapy. So PT and OT are designated health services, but know how you bill. Oh, a speech, oddly, is not a designated health service. So if you bill incident 2, you need to have a doctor on site, but you do not need to bill incident 2. And in fact, I would say you should not bill incident 2. And so that means you can have multiple physical therapy locations, right? You can then see Medicare patients at each one. You can see new Medicare patients. So this is, if you're billing incident 2, your doctor needs to see all the new Medicare patients and order the therapy. If you're not billing incident 2, that's not true. And the reimbursement is the same whether you bill incident 2 or not. Physical therapy is reimbursed whether it's billed under the PT or under the physician at the same rate. So I would say bill under the PT, you can then have them off-site without physician supervision, and you can see new patients. People get this wrong a lot, but it's really clear. So you can be off-site as long as you control that location 24 hours a day, 7 days a week. Now, we've got a few questions here. So I will say after these slides, I'm just going to show you in the handout, if you go, you'll see the same building analysis that's there. So what do we got, Katie?
All right. One here clarification that's important to make is that doesn't the Antimarkup statute and rule apply only to those services paid on the physician fee schedule? It's a great reminder that the Antimarkup regulation is limited to services that are performed by a physician or other supplier. So it's not totally correct to say it's just Medicare physician fee schedule, but it's about services that are performed by a supplier, which would not be a hospital.
Correct. So,
but interestingly, hospital services in the outpatient department that are off campus that are not grandfathered are paid under the Medicare physician fee schedule now. So that's why we can't totally say they're it's physician fee schedule.
Yeah. So that's an excellent clarification. Thank God Katie's here because I don't think I would have gotten that one right. So that's a great point. Okay, please clarify if there's no signed order for a diagnostic test, like a CT for lab, or CT or lab for a hospital doing outpatient testing. So so first, ask the doctor to sign it, right? I mean, just let's be practical, better to have it signed. Would I refund money because of a lack of a signed order? Heck no, I don't think you need to. Try to get them signed, but I don't think you have an overpayment if they're not signed. How is that logically consistent? Because an overpayment only exists when you've broken a clear rule. I don't think there's a clear rule that those puppies need to be signed. And so I'm very comfortable with that, which is, just to be clear, I'm not saying tell your doctors not to sign. Tell your doctors to sign. If you see an unsigned one, ask them to sign. But don't refuse to do the test and don't refund the money.
Okay, here's another good one to unpack. Can a licensed APRN, advanced practice nurse, provide direct supervision of wound care nurses in a hospital outpatient wound care clinic? Okay, so, and then it says the hospital would bill for the E&M services, and can the APRN sign off on charts? All right, so let's unpack that. First of all, what are we talking about? We're talking about, I think, therapeutic services. Who can supervise therapeutic services in the outpatient department? Certainly it can be someone other than a physician. So that's kind of unpack piece number one. Then it says the hospital will bill for the E&M services. So maybe these aren't necessarily therapeutic services, but they're professional services. And in that case, you would have to make sure that whoever's providing those professional services is one who's doing it within their scope of practice and authorized to provide those professional services to Medicare. So I don't know that an RN could provide an E&M service and bill to Medicare, unless you were in the clinic and doing it incident to, but here I think we're in the outpatient department. So it's a tricky one. It's going to depend on the setting, the service, and the level of supervision.
Yeah, but if it's an NP.
If it's an NP who's doing the E&M, then they can bill. But if it's other wound care nurses who aren't NPs, then would have an issue with E&M.
I'm totally with you. Let's just finish. We'll do the announcements, and we'll come back for questions. But just remember, next webinar is April 11th, and that's going to be healthcare business development team. So people who are kind of investing in the healthcare world. If you've got someone who's in there, you can always forward the invitation to them. You will get a survey. We're not going to send it out right now. We'll send it out in a couple of days. We'd love to hear new topics and feedback on the various questions we ask there. Those surveys are truly anonymous. So if you say, I'd love a lawyer to call me on there, and you don't put your name, you will never hear from us because we will not know who you are. Not many things in the modern world are anonymous. For better or for worse, our survey is. I think that those were the only things I want to mention here. We got a few more questions. Could you please restate what you mentioned in regard to DME in a group practice and CPAP machines? So sure, if you're in an urban area, you can't own CPAP and give it to Medicare patients for sure. Medicaid patients, probably. Rural is a different stark exception, so rural, you're okay. If you're see, I didn't do it perfectly. If you're urban and physician-owned, if you're a nonprofit in an urban area. And so what's the difference, do you think? Well, Stark looks at ownership. And so if the doctor doesn't own the clinic, then it's okay. And, I guess I owe everyone an apology for not having made that clear on the first one. And it shows just how hard this stuff is, right? So if it's a physician-owned clinic in an urban area, then you can't have CPAP. You got a few more? What do you got? You got one?
Okay, let's see. Can a pathology lab owned by a group practice provide testing for outside providers? The plan would be for the path lab doing path to bill Medicare and let the outside provider bill commercial.
I haven't, but I wasn't listening to another one, so this one might be, let's see.
So in this case, this is going to be a group practice Stark question. And can they bill for testing provided by outside providers?
Well, there are a whole bunch. And actually, it sounds like
if it's just ordering by outside providers, then there's not a limitation on billing.
So part of what's going on here, this is the classic question, right? The big thing here is, conceptually, can you do this? Yes. How different can you have your prices be? Is really the big question here, right? So if you want to bill Medicare $100 for these things, and you're going to let them bill commercial, but you're going to bill them $50, and they're going to bill commercial payers $100, I'm going to be kind of nervous about that, right? If you're billing $100 to Medicare and $90 to them, and they're billing commercial payers $110 or $120, that's probably okay. All right. Can an urgent care center owned by physicians do x-rays with an APRN on site, no physician on site, and bill Medicare? So if it's plain film x-rays, you only need general supervision. And so it's not that the APRN on site is doing the supervision, it's that you've got the right level of supervision because you just need general. And the doctor can be off site and you're good on general.
That's good.
And so general saves you. If you were doing MRIs with contrast, having just the APRN on site would be insufficient. But for plain film, you know, if you're just doing like for pneumonia and basic breaks, you're fine.
Can you revise a diagnostic lab order to meet medical necessity after the test has been completed? It's sort of so I think this is, can you revise the order? I don't usually think of the order as much. The order is just, I want this.
I'm not sure that I understand. I'll tell you this, I don't like
but medical necessity can be established by outside of the order, and should be, in fact. You know, you're going to order it, and then the record is going to demonstrate the medical necessity.
I think that's the right way of looking at this, right? If you had them, so let's turn this into, if you were merely missing the documentation for medical necessity, that doesn't make it not medically necessary. You have medical necessity. So can you retroactively document the medical necessity? Sure.
Absolutely.
If there wasn't medical necessity at the time the thing was ordered, can after the fact discovered evidence get you there? I would say
probably no.
I don't know how much longer we want to go on. I mean, we've got questions, and we can stick around. You know, if you have to go, you go, but here are a couple more. We're looking to add a PT clinic in a fitness gym. The gym will be closed to patrons the hours we're in the clinic. Is this a Stark issue? So if you're doing PT and you're billing it, Stark applies. If you're billing, assuming Medicare or Medicaid are in the mix. If Medicare or Medicaid aren't in the mix, then Stark doesn't apply. That doesn't make it a Stark problem. You could have this be compliant with Stark. So, but I think that this one goes into the need to know more camp. Let's see here. Oh, this one looks too hard. That one looks hard. So that's you stumped me. If I had a prize, I'd hand it to you. Let's see. I don't know if we answered this one yet. Hospital outpatient surgery centers can only be located on campus. True. If it's a hospital you could be
well
it could have been
department can be off campus, and it still can be, but you're not going to get the provider-based reimbursement.
And you can't do a new one. There could be one that's out there today that's out there.
Right. And in fact, you could even augment the one that's out there, so long as you don't change the suite number and address. But you couldn't establish a new one or move to an entirely new address. Well, you could, but you wouldn't get the enhanced revision.
See, Katie's making that point. This is the complicated of what you can do versus what you can get paid. I think we've covered most of them. Thanks to everyone for listening. I hope you'll fill out our evaluation. And happy Pi Day. Oh, I'm happy. That's the eve. It's happy March Eve.
Happy March Madness.
Yeah, and yes. Oh, happy March Madness. Who's going to win?
Villanova.
Go Blue. Michigan, go Blue. All right. Thanks for listening.